to the IFA Global Cafe in Conversation with Expert. My name is Jun Wang, Special Project Officer with the IFA, and will briefly review housekeeping. We will begin this virtual cafe with opening remarks, which will be followed by a moderated question and answer session. Please use the chat function along the bottom of your screen to indicate you have a question or comment, and we will call upon you to post your question during the moderated discussion. If you have resources to share, please post them in the chat box as well. The virtual cafe is recorded and streamed live on the IFA Facebook page. The video recording and resources will be made available on the IFA's website, and you will receive a follow-up email with these resources and an invitation to the next virtual cafe in the series. Now it is my honor to introduce the IFA Secretary General, Dr. Jean Barry. Jean?
Thank you very much, John. Good morning, good afternoon, and good evening. During the time of COVID, but really before COVID and probably afterwards, we understand healthcare services should be distributed through interventions and demographic groups in an ideal health system. And that's to achieve the highest possible overall level of population health at the lowest cost. However, we are all living in countries where our healthcare systems have not only been challenged, we've recognised them as inadequate and at times, difficult to respond to the problem at hand. We're going to be in conversation with Dr. Katherine Mcgilton today, and Kathy is an expert on the intervention studies and models of care, and focusing on enhancing the care of older people, especially those with dementia, through the development and application of interventions, outcome measures, and models of care in practice. One of the enjoyable parts of my job is I get to work with and talk with experts around the world. And what caught my attention in talking with Kathy earlier this week is the way that she applies her research in settings. And that doesn't always happen with academics. So I know that, this session today about models of care, really is at the heart of the conversation around healthcare systems. So let me just tell you a little bit about Kathy. Dr. Katherine Mcgilton is a senior scientist at the Toronto Rehabilitation Institute University Healthcare Network and a professor at the Lawrence Bloomberg Faculty of Nursing, University of Toronto. She has research funding as the principal investigator from the Canadian Institutes of Health Research, Alzheimer's Society of Canada, and the Ministry of Health and Long-Term Care. She was recently, and congratulations, Kathy, recently inducted into the Canadian Academy of Health Services for her work in the field of ageing. The results of her program of research have led to innovations in models of care and positive outcomes for older adults and staff in long-term care, homes and rehabilitation facilities. And these have been translated into protocols that guide the provision of care in these settings. A much needed conversation, and we welcome Dr. Katherine Mcgilton. The floor is yours, Kathy.
I want to thank you for this wonderful ability to actually speak to many people from different countries. I'm thrilled that I've had the opportunity, and I want to thank IFA for this. And I also want to say good morning, afternoon, and evening to all of you today. So I just want to talk about the current crisis and how it's really ingrained a poor status of the workforce that's taken for granted and ignored often in our long-term care homes. Despite them trying to support the health and well-being of the residents that live there, often our most vulnerable older adults in society. So I'm going to talk about today, my interest is really looking at what happened in some of our nursing homes and actually provide some wonderful ideas for moving forward. How can we improve some of the models of care that are taking place right now in our nursing homes? We all know that the majority of residents today in our long-term care homes have multiple chronic conditions, and most have mild or moderate dementia, and all of this leads to very unpredictable and complex care that require knowledgeable assessments and interventions by the qualified healthcare staff, and in person preferably. And I'll make a note of that and tell you why in a minute. As you know, or maybe you don't know, in Canada, one of our great shames as a national tragedy is the number of persons that have died with COVID-19. Many, up to 80% were in our nursing homes, especially in wave 1 and 2. Luckily, for wave 3, many have been vaccinated, so we haven't seen quite the tragedy as we have seen previous. But most of my research, actually prior to COVID-19, focused on the important role of registered nurses in nursing homes. And usually they are the most qualified staff in nursing homes. We often have registered nurses, then we have registered practical nurses, and then we have nursing assistants. And in your countries, you probably have similar models of a sort of hierarchy, but also different levels of skill set. What we have noticed over the last 15 years is really a diminishing of that RN role. We have very few RNs right now who are actually in nursing homes. So what does that mean? That means when I was doing research in this area, there are very few RNs that then supervise the personal support workers. Their role has also changed over time. These RNs often are doing more administrative and management roles. So they're actually not clinically available to the residents. And so that actually, when you think about a perfect storm, that sets us up for an issue when most of our residents become quite complex and ill because of COVID-19. So we've eroded the role of the RN. And because of this, when COVID-19 came, the clinical skills of some of the staff were not aligned to the needs of the residents. So the critical needs, some of our RNs hadn't done very good physical assessments over time. And again, no fault to them, but the new models had caused them to do more work like collecting data. So we had a bit of an issue. One solution was hiding in plain sight, and they're called nurse practitioners. And I'm going to tell you a little bit about them. And I have to tell you, I was blown away when I started doing research, looking at the work they were doing in nursing homes. And we're going to share an article with you in the chat box about this. So who are nurse practitioners? They're RNs who are master's prepared and they diagnose and treat illness, they order and interpret tests, they prescribe medicines, and they work collaboratively with the staff in the homes to provide the best care possible to the residents. COVID-19 really has underlined the importance of having on-site clinicians that are doing these assessments, because we need care that's timely and we need to follow up. And this is what we found the NPs were able to do. Nurse practitioners, we believe, represent really an efficient solution to human resource challenges. And I'm going to tell you why that is. But I want to tell you, when I did look at the literature, there actually are nurse practitioners in a variety of settings. We know they're in Australia, they're in Finland, Ireland, New Zealand, the Netherlands, the UK, of course, the US and Canada. And there are some countries in Europe as well. And so, but what's interesting about that is they have different levels of responsibility, autonomy in practice in different countries. And so I'm going to talk about what happens in Canada as a possible model for different countries moving forward. So the role and the scope of nurse practitioners in long-term care have evolved over time, and may, like I said, be different in your own country. Now, what happened in Ontario specifically? Well, in our long-term care homes, we often have physicians that actually act as the most responsible care provider. But during the pandemic, they were asked to work virtually, and that's because they have multiple responsibilities across different sites. I have heard that many were kind of upset they couldn't go in, but in fact, they could work virtually because often they have multiple nursing homes, or they work in Emerge, or they have their own family practice units. So they only could work virtually. And remember, the complexity of the clients that we're caring for, it's very difficult to do a virtual assessment if you don't have somebody in the nursing home that has incredibly good physical assessment skills to be able to give that information over the phone. So again, I may talk a little bit about some of the skills sets that are lacking in our nursing homes for some of our RNs. So in turn, there was a challenge for staff to contact medical care for residents, especially any type of on-site care. And in response, in Ontario, there was an emergency act, the order that went in March of 2020, enabling nurse practitioners to actually act as the most responsible provider and actually the medical director in the nursing homes. This is the first time this has ever happened. Let's just say, as an applied researcher, this was an absolute beautiful example of a natural experiment that I had to take advantage of, because I'm thinking, well, what difference did it make when our family physicians were actually not on site? And again, I'm saying this, a majority were not, but there were some family physicians that were still able to enter, but the majority were not. Nurse practitioners, however, were actually on site. And I'm also going to tell you we have two different types of nurse practitioners in Ontario. One group are called attending NPs. They're funded by our Ministry of Health, and there's 50 of those in the system. And what happens there is 50 homes then said, hey, we would love this attending NP. And that person was responsible for the care within the one home. So they provide oversight, clinical oversight, and I'll tell you more of their responsibilities in a minute. But we also have something called nurse-led outreach teams that are NP-led, and those people are hired through acute care facilities. So another program that happened about 10 years ago, where we realized there was a lot of our elderly that were coming from the long-term care environment to emerge, and we realized some of those probably shouldn't have come to emerge. We probably could have prevented that ER admission if somebody with more clinical skills had been in the nursing home doing an assessment and working with the staff to prevent those admissions. And that's exactly what the role of these nurse-led outreach teams were. And actually, one nurse in this model usually oversees between 5 to 15 nursing homes. So again, they're not on site all the time. They're there more for acute episodic needs. During COVID-19, however, most NPs in this model of care made decisions to go into the homes that actually had the most outbreaks. So between themselves and their directors in acute care and the discussion with long-term care homes, they said, you know what, you need more help. How about we choose one of the homes that's doing poorly and go in and try to make a difference? And so what happened then is I had this opportunity to write a grant and say, hey, how about I interview nurse practitioners that were in these nursing homes to find out what it is they did when they went into these homes. And this is where I tell you I was blown away. I'm not a nurse practitioner. I am an RN. But I have to tell you, they impressed me, and I now have some great stories to share with you. And I believe this is a model for the future in terms of really improving best practices in nursing homes. So what happens when first of all, why do we need them? I have to tell you that this group has been researched over many years. So what does that mean? There's evidence that they actually produce cost-effective care in nursing homes. They have a reduction in polypharmacy, and they actually order the right medications. They transfer to acute care, usually are decreased, and they're well positioned to lead and respond to the complexity of care. They've also, when you look at satisfaction rates of the families and the staff, it's incredibly high when you bring a nurse practitioner into the fold. Administrators can't believe what they can offer. In terms of clinical leadership, they improve access to timely care. So again, in our model, sometimes it's difficult to actually access a physician. So sometimes they're able to provide a little quicker care because they're often the sole provider. And they provide preventive care. So this group actually looks at how do we re-able clients? Because we've also heard stories that sometimes when we're living at home and some of our abilities may be declined. And once we go into nursing homes, there's actually an ability to really get our function back. And that's actually what nurse practitioners attempt to do. So we're trying to provide high quality management also of any kind of chronic diseases. So then the question is, what do they do during the pandemic? And this is what I want to tell you. I was very impressed. So working collaboratively with any staff that were left within the homes, their main areas of focus were containment of the spread of COVID-19. I'm going to talk a little bit about that. They provided direct clinical management, care for the residents. They supported the families, and they established links between fragmented models of systems of care. And of course, they supported the staff. And the first was really around the containment of the spread. The education they provided in terms of PPE and IPAC use, the role modeling, they were there teaching the personal support workers, our healthcare aides, how to don and doff, take off their equipment. Because remember, a lot of our staff, probably like your countries, English is a second language. So it's very difficult when you're sending them information over email or video, to read and to take on. It's actually quite complex. So some of our staff, of course, did in the end get COVID-19 because we weren't able to be there to help them. And in fact, a lot of leadership was offered to staff. You can imagine when our NPs went in, along with their staff, with their leaders, they had to try to convince the staff to stay. The staff were so worried. And that was a big part of their job, trying to provide the education to support them and providing the oversight to support these anxious staff who were worried about contracting the virus and, of course, bringing it home to their family members. Remember, most of these are caregivers. They're taking care of their the elders in the long-term care, but also they're probably parents. So here's a quote from one of the NPs. She says, there was a lot of things we had to put into place very quickly. So those kind of policies I did because there was just nobody who had the time. When our nurse practitioners talked about going into the nursing homes, the administrators were doing their best to understand what was the right protocol, what did Public Health Agency of Canada want them to do tomorrow. They were constantly trying to deal with that, where the nurse practitioner was able to be on the unit and provide the actual transfer of the best practices into working with the staff. The other thing they did is they provided direct clinical support. These clients, as you know, were incredibly complex when they were struck with COVID-19. And so, in fact, when we first started, they weren't really sure what were their best practices. So again, they came up with working together. They developed a collaborative where they would work with physicians and their other nurse practitioners through the province to find out the best care practices for this very, very complex group of clients once they got COVID-19. They started learning how to decant, cohorting them into different areas, provision of very acute and episodic care, and really palliative end-of-life care became crucial. Because if you can imagine, when they walked into some of these homes, some of these clients were not doing well and had to very quickly phone families and try to determine when and if they were going to ever be transferred to acute care, or could they put end-of-life practices into place ASAP. And the other big issue, of course, was social isolation. And I'm sure, Jane, you probably had some experts speak about this, the importance of once you had these clients that were COVID-19 positive, how do we keep them, especially if they happen to have a late stage dementia, in a room and without sedating or restraining them. And so this was another big role that nurse practitioners took on, leading the staff, providing best practices on how to support them so that they could continue to live as meaningful lives as possible during COVID-19. And this is where they worked along with staff to do this, with the remaining staff that were there. And so one of the nurse practitioners says something to the effect of, I was acting as the most responsible provider. I was making all the decisions, treating all the residents. So again, I just want to let you know that some of our nurse practitioners would even comment of this natural experiment. They would talk about times where in Ontario, we have a collaborative model working with physicians. So nurse practitioners work with them and they'll say, here are some of my comments. What are your thoughts? And again, sometimes that's virtually, but before COVID-19, it was probably in the same building. But some nurse practitioners said that over the period of 4 to 5 months, there were 5 times where they actually had to phone the family doctor. So they themselves found it a natural experiment and wondered how well could they manage. And in fact, the 5 times they did phone, or of the 5 times they phoned the family doctor for his or her advice, they said 2 times was because the family members wanted them to, and the other times were because they were ordering tests that were outside of their scope of practice. And that's a CT scan, and that's hearing aids. Walter Riches, I saw you on here. Believe it or not, nurse practitioners can't actually get hearing aids for clients. So again, there are certain scopes of the role we have to think about, and when we move forward, maybe we need to reduce those barriers. The next thing that they did is they supported families. The unbelievable grief, strife that families experienced during the time that they were locked out of our nursing homes. This was probably universal, but for sure through Canada. Family members were not allowed to be in the sites. The pain and suffering that caused, what nurse practitioners tried to do, along with all the staff working in the sites, was update the families as much as possible. This became such a big part of their role. They said on some days there were multiple calls made to a family member because the client was changing so quickly over the day. They kept them involved, they informed them of their status, and they updated them on their plans of care. Very important work, and communicating with families to try to keep them abreast of the situation. And of course, this is also where They, plus of course, recreational therapists brought in the virtual care, where we had iPads donated, and in some facilities where they could start trying to make those connections with loved ones. The other thing that happened, which was interesting, and for those of you that do work in nursing homes, you know, prior to COVID-19, I have to tell you, we work in silos. Unfortunately, our healthcare system is all about silos. And long-term care felt it more than ever. And the one article that you'll see that I wrote, I called it devaluing our healthcare staff. We really felt isolated when COVID-19 came in nursing homes. We spent a lot of energy making sure acute care was taken care of, and they did survive. I have to tell you, it's not going so well. Faced wave 3 in Canada right now, especially in Ontario. But anyway, in wave 1, they were sort of abandoned. They felt abandoned, the nursing homes. And we do not have good systems of care. We do not have integrated care. So we didn't really get a lot of the PPE supplies like others right away. But what I have to tell you is the nurse practitioners, again, because some of them already were connected to acute care, and this is the beauty, they brought those connections and highlighted them and used them very well during COVID-19. So they developed some collaborative models with acute care. They developed algorithms to improve access to specialists and emergency care consultations. They actually developed virtual care. So in the past, some of the residents actually weren't able to access some of their specialists unless they went out to the facility, which actually was very difficult for some. So in fact, they set up virtual care. So now they could speak to urologists, they could speak to cardiologists virtually. And that made a huge difference in the care of the residents. And we're hoping that virtual care continues post the pandemic. They developed algorithms to determine who should be decanted to the acute care. They supported emergency department avoidance programs. They created them, and they developed flow sheets to, like I said, so other doctors and also nurse practitioners knew exactly who to contact and when. And lastly, I think I want to talk about what I thought was most critical, where most nurse practitioners spent a little bit of their time doing this prior. But I'll tell you, during COVID-19, like never before, they supported the staff in the homes. And they realized that without staff, you cannot have quality care. And this has always been my mantra, and this is why I focus so much on the health workforce. You have to have staff, but you also have to have staff that are happy. Most staff work in nursing homes, most of my research shows, because they love the residents they care for. It's about being in relationships with them. But we have to also be in relationships with our staff. So my models of care have always focused on having a supervisor that actually cares for the resident and the staff, because we want to hopefully have that trickle down effect. I'm going to have a pause and a coffee because I heard it was a coffee cafe. So, And I'm going to apologize because I do speak quickly, and I'm hoping if you have any questions about what I've been asking, you can ask me if I wasn't clear. But anyway, in terms of what the nurse practitioners did, because remember what happened in our homes, a lot of our RNs, and remember there's very few of them, and even our registered practical nurses who are in supervisory positions got sick. Full-time staff were going in and getting sick. And so what we found then were some of the nurse practitioners came in and provided that supportive role in the homes and kept staff there. I don't know how else to say it. They retained the staff. We had one experience where an RN, she says, we lost about 30 to 40% of our workforce right off the bat. And she brought an RN in to live with her because she said this way she wouldn't quit. They went above and beyond to make sure they could keep staff. They said things like, I did more mental health in the first month than I've ever done before in my life. So taking care and mentoring staff was incredibly important. The other thing they said, which speaks to our need to make sure our staff have the skills, is they actually provided mentoring at the bedside. I spent a lot of my career trying to improve practice. It's so hard. It's also, I think, it's because we have ingrained practices. We've done it this way all our lives. Having somebody come and tell me that we can do better practices is really hard. I think that's where nurse practitioners shone. They were at the bedside showing people how to do things differently, how to do better physical assessments, how to improve the way we isolate clients, but they were with them, and that speaks volumes. So You can't change practice without being in relationships with people, building trusting relationships, and that's what NPs did during this time. And I think care improved because of that. I don't think we have big data yet to prove that nurse practitioners saved lives, but I'm pretty sure they did. I know they kept staff in the buildings, and they built teams to really focus on best practices. So in conclusion, I think we need new models of care in our long-term care environments that are actually going to support staff, enhance their skills, so we will have better care and quality of life for the residents that are there. We need nurse practitioners in our nursing homes, where we are now maybe trying to make a stance that maybe we need one nurse practitioner for every 100 to 125 residents, but that is also for every perhaps 50 maybe staff, because that's also important. We can't forget that new practices are coming and that we need somebody to mentor and show the way. And I think this is the solution. And I'm going to end there and ask who has questions.
Well, Kathy, look, thank you very much. And I've got a question, but I'll leave that to a bit later because we do have questions coming in already. And I will, on behalf of Carlos, ask you the question. How do we deal with the accumulated complexity of older men and women on the way to 2060? How do we face long-term care without skills and or competencies to manage the emotions that co-create complex chronic diseases in times of old age with poverty without borders? So that's a big question, but I'll hand it over to you and then I will ask other people to step up. So,
yeah. So wow, so that is a big question. So how do we deal with the complexities, the emotional? I think we have to take care of the staff first. I think we have to educate them, train them to them, like you said, multi-complexity of the individual. What is, person-centered care? It's really understanding what matters to the individual. It's their culture, their beliefs. We have to get at what's important, what matters to that person. And that's really quite complex sometimes with cognitive impairments, but that is really the key to quality. Trying to find out what makes them tick and providing the services that are required. I want to stop and say, I feel like I focused a lot on sort of the physical care needs. And again, COVID-19, first we have to think about airway, breathing, ABCs. That was important while they were so physically ill. But of course, their emotional health, their physical health, spiritual health, that's all very important. And I think that's where most leaders in nursing homes then have to make sure they have the right personnel to take care of all those needs. Because I would also suggest that we don't have the right people to create the best care systems in these homes either. So we have to think about what are their needs and who are the right people to be in the homes to create and care for them so that they do have those moments that matter.
Kathy, I just want to go back to your comments about relationships. And I often say to my staff, IFA is built on relationships. We can do what we do because of relationships. And I often wonder about, our work at the United Nations in working to hopefully one day have a UN convention on the rights of older people. And what relationships do we need to actually sustain to create that trust? So I now shift to ask the question about government and influencing policy. And earlier this week I said, have you been involved? Are you informing the government? Because clearly you have uncovered in this work and before the importance of new models, but based on relationships. So can you talk about the importance of having a relationship with policymakers and how do you actually shift from this policy to this policy in times like this?
What an excellent question. So when I was schooled, and I don't know if my mentor's on, Dot Pringle, when I was doing my PhD, it's all about the science, getting the education so that you can get out there, create the good studies, build your career and make a difference. And they didn't really tell us about Policy 101. I had no idea how to infiltrate that world. And it is a bit, I don't mean to infiltrate, that does sound kind of interesting, but build relationships is a much better way of saying that. And it's taken me a few years. And to be honest, I've watched a few other people, some other colleagues who somehow were getting grants from ministry people. And I thought, how are they doing that? What's going on? So how do they have the ear of the individual? So I actually watched them work and learned from them. And you know what they did? They actually started knocking on the policy decision makers' doors. And I thought, oh my goodness, is it that simple? In a way, it's not, because you have to prove and you have to make sure, they'll even open the door for you to come in. But I started doing this, and it was actually quite fascinating, the difference it made. I haven't been quite so fortunate to open up doors well, to be honest with you, I have very good relationships with both OLTCA, TCA, and Advantage Care. So those are, are not-for-profit and for-profit nursing home organizations. But in terms of policy decision makers, not so much. But I have started opening doors in other areas with Ministry of Health individuals to say, hey, I've got some work here that's actually relevant. Can you co-design with me and work along with me, so that if we have some good findings, maybe together we can actually change what's going on. The other thing that I had the opportunity of being involved in, Jane, which I forgot about, is when I was in my career early on, I was an early career researcher, which meant the Ministry of Health provided funds for me to do my research. And one of the paybacks was I had to go and work within the Ministry of Health and to do a project. I can't believe I forgot this. And at the time, believe it or not, the Long-Term Care Regulation Act was changing. This was 2007, 2008. So actually they asked me to be involved in that. And I have to tell you, some of the researchers said to me, I can't believe we have to do this. I said, I'm so happy we get to do this. Talk about exciting, getting to change policy. And one of the things I did was the long-term care regulations, there was, I don't know, thousands of pages. And in every page it talked about challenging behaviors, because that was a focus of what are we going to do in Ontario to deal with people and their challenging behaviors. And I actually at the time was reading work by Sherry Dupuy, who talked about, why don't we get rid of that language and call it responsive behaviors? Let's talk about, instead of blaming the resident and calling them a challenge, saying maybe they're responding to an unmet need, and maybe we should be doing something as healthcare clinicians to meet the needs. And I loved that philosophy. So I told the lawyers, I said, you know what, let's get rid of that find and search. Can you please go in there and get rid of the word challenging in every other page? And they said to me, Kathy, is this the flavor of the month? I said, this is the flavor of the future. I said, if we're going to do things well, and we're going to teach our staff how to actually deal with persons with responsive behaviors, instead of just saying they're challenging, let's shut the door, which unfortunately still happens, we have to still understand what's happening. And you see, this was my other objective. We have to have qualified staff. You actually have to have someone like a nurse practitioner going in there and an RN who's skilled up to do a very thorough assessment to identify, is it because they're lonely, they're constipated, they have pain? What are the reasons why? And actually they changed the regulations. So Jane, I kind of have, I'm going to say drop the ball a bit, but trying to get into the right people's path has sometimes not been one of the best things I've been able to do. So you're right, I need to focus my energy on trying to influence policy. I put my name forward for the long-term care standards group in Canada, but I have to tell you, there's probably another 100 researchers like me that put their name forward. And I don't speak French, even though my middle name is Simone. And I apologize for that. So that's also not good, because they're looking for people that speak both languages. So,
yeah.
Anyway.
There's only one Kathy Mcgilton. That's the difference. And I think also, you understand how to influence policy. So, and you haven't dropped the ball. I would like to go to some questions. I'll start with Monica, Kathleen, Iragua, and then Indu. So Monica, and perhaps if we have Monica and Kathleen, and then we'll go on to the other two. So Monica, are you with us?
Okay, it's my time to talk.
Yes, it is. Make your question short, Monica. We've got your question in the chat box. So,
Okay.
What's your question to Kathy?
Thank you, Kathy. I work with visiting hospice, and we often visit the facilities. And one thing that really is interesting to observe is the lack of one room in the facilities adapted to palliative care. And of course, training to the nurses and PSWs for palliative care. It would be such a simple measure that would give more comfort to the client that is dying and would avoid so many visits in crisis to emergency. Where are we at in terms of palliative care rooms with a space for a caregiver to be together with their loved ones in the facilities.
Okay, thank you, Kathy. Kathy, I'll just go on to Kathleen Brasher from Australia. Kathleen?
Thanks, Jane, and thank you, Kathy, for your presentation. It was very interesting. Most of our deaths in Australia from COVID have been in aged care facilities, particularly those owned by the private sector. The greatest demand was for infection control knowledge and understanding. I live in a rural community, and our struggle was that we have one nurse practitioner that covers numerous aged care facilities, and your comments about relationships were so vital, but she was prevented from visiting because you couldn't work across different aged care settings. So I'm just wondering if you could comment on how we can make the most of the role and still maintain those very important relationships.
Thanks, Kathleen.
Great question. So Monica, in terms of palliative care, I think there are some wonderful guidelines coming out, especially during COVID-19, what we need to do, and we can share those with you. Shirin, my PhD student, I think she's on the call, helped develop some of those. But right now in Ontario, there are some family members, and I think they made some, how is this? I want to say breaking the rules. I don't know if that's the right way to say it, but I think some family members were slipped into nursing homes during some of our times, especially when clients were dying originally, because they could be there, if not at least through a window. There were ways of trying to connect loved ones. It's incredibly painful at first, though. I think nobody was allowed in. But upskilling the staff is incredibly important. What skills do they need? Because you're absolutely right. We don't want to be discharging these clients to emerge if that's not where they want to go and die. And in fact, it's almost sometimes we just need to let them know that is not the preferred way to die when you don't know anyone and you go to a cold acute care unit where people don't know you. So a lot more education on why dying probably in the home is probably best. Plus, what are some of the skills that the staff need are paramount to make sure we have better palliative end of life care. And just get in touch with me after if you want some help on what we were doing during COVID-19, because there were new rules put in place, absolutely, on how to do this better. In terms of Kathleen numbers, I think we have to start making an argument that one nurse practitioner over so many homes is not okay. It's not good enough. I think we continue to pretend that knowledge translation happens well when you oversee 10 or 15 homes. There's no evidence. We don't see changes in practice. You need someone mentoring at the bedside. I think we don't give that enough credence. So, in terms of, and I have probably a couple of colleagues here that are nurse practitioner in-laws, they might have suggestions of, trying to leave, work with one professional or charge nurse within each facility, perhaps, trying to upskill them. I think often our best advanced practice nurses leave the skills behind. Like in the end, when one of the nurse practitioners said the best bang for my buck was doing mentoring at the bedside, it's because she knows if she does this 2 more times, she might never get that call again from the RN, because the RN will eventually be able to do it without calling her. And that's what your nurse practitioner is going to have to do. It's at that fan out model. Teach one star, and to be honest, it could be a personal support worker. Whoever has the interest in learning about infection control, they become the person that she can virtually work with, at least, to provide the kind of care that then that individual in the home can mentor and teach others, with the nurse practitioner constantly going and providing QI, audits, and helping them. I would recommend that kind of a fanning out, but obviously we got to start putting money where it counts. And I think we've got to start hiring more nurse practitioners. I think we can't just say this is going to go away. The complexity of the residents, who are we kidding? They're very complex. We need people that are skilled to care for them, and we have forgotten that. And that's what I think is a big tragedy. And that's what COVID-19 showed us. Some of our clients weren't dying from COVID-19. We were dying, like they said, for containment disease. There were other reasons, and that could have been prevented if we had knowledgeable staff, I think, in some of our homes.
Thanks, Kathy, and great questions. Iragua, are you with us?
Yes.
Okay.
Hello.
Hi, please talk to Kathy.
Yeah, thank you very much, Catherine, for the great presentation. My name is Ilaguha Moses. I'm from Uganda in Africa. My question is, I work in an area where, in Uganda, where we are still young in the provision of services to the elderly, and the situation is really worse for mostly patients with dementia. I was asking whether there are any recommendations or suggestions that you would have for the care of these older persons who are in their need of services. In brief, I would say some of the challenges they face is the understanding of the problem, because most people have a negative attitude towards dementia. They don't understand what it is. So are there any recommendations you would suggest that would be helpful? Thank you.
I think also, Raghuwat, you were mentioning, in African countries with limited and non-existing nursing homes, what can be done? So, Kathy, perhaps if you can respond to that question.
Absolutely. So, I mean, I think, caring for someone with dementia is complex, and like you said, the stigma around even the diagnosis, and then going from the care provision. I guess what we're trying to always focus on are abilities. What are persons with dementia still able to do? What are the remaining abilities? So sometimes when we get these diagnoses, we think we can't. Absolutely, that is the wrong way of going about it. In fact, there are many remaining abilities for persons, especially when you're newly diagnosed. You probably still can do quite a few things. Yes, you have memory lapses. Yes, there are some medications to help with some of that. But really, we're looking at what can they still do, and how do we continue to enable those versus disabling. I want to tell you what we do sometimes not well in Canada is when we see our clients, we often think of a trajectory down. So what can they no longer do? And we actually cause some dependency. So we have to understand what they're still able to do and work with them so they maintain those. And I'm going to give you an example of when some of our clients, and we walk maybe into a home and you say, put on your shoes, put on your coat and come walk with me. And they may just sit and stare at you. But if you actually say something like put on your shoes, they may do that. And that's because they no longer understand 3-step commands, but they might understand 1-step commands. So there are actually some very good materials out there. So you can contact me after on how to teach staff, but also caregivers on how to maintain our abilities, but also our approach to persons with cognitive impairment, the way we ask. For instance, you can say, do you want to go for a walk? And 9 times out of 10, they may say no. However, if you say, come walk with me, they'll walk with you. So I also spend a lot of time working with staff on better approaches with persons with cognitive impairment so we can maintain their abilities.
Okay, thanks, Kathy. We've got 3 more questions and I'd like to get through all of them. So it's Indu, then Cynthia, then Valerie. So Indu, could you just give Kathy your question? Okay.
Can you hear me?
Yes, we can. Just
Okay.
the question, Indu.
My question is there alternate way of helping a senior live at home with the help and support? I'm in Ottawa, and I come from a ethnic community, and I have seen that, and I want to do a survey for the ethnic communities to see how can they keep their seniors at home and what are their needs, and can then approach the system that how can we meet those needs. Do you have any research done on that? And is there anywhere I can get more information to start this research?
Okay, I'll stop you there. Thanks, Indu. We'll go to Cynthia and then we'll come back. Cynthia?
Okay, thank you, Kathy. My question is, I'm very hopeful, but do you think that the supply of geriatric nurse practitioners will fare better than we've done with the medical profession and recruiting physicians to go in to be geriatricians?
Okay.
Thanks, Kathy.
So Indu, let me start with you. I've not done a needs survey of persons living in community to find out how they could stay at home, but I'm pretty sure one of my colleagues has. So how about you just connect with me afterwards, and I can probably find somebody that has a similar interest as you. And of course, you're absolutely right. Everybody wants to stay home. Nobody wakes up saying, I can't wait to be in a nursing home. So I think that is an important area to focus on. How do we keep people in their homes? And we know there have been, unfortunately, again, many reports written in this area, we do not have good community supports. End of story. And this is why some of our elderly end up going into nursing homes, because of the care that is not provided for them in the community. And I know when we were talking about looking at long-term care standards, the unfortunate part is that is also a bit of a siloed approach. It's like we need to develop a healthy framework for seniors, for health, like to develop a healthy system for seniors. And we got to stop looking at silos. We have to start looking at, the money is going to come for almost a bundled approach. No matter where we are, we need services. And that has to change, because right now it's very difficult to live in the community unless you have extra resources. And that's usually money. And not all of us do. Well, thank you. But Indu, please get in touch with me. I'm pretty sure I could help you find a survey to help survey your group. Okay.
I'm sure you're going to have half the people on the call contacting you, Kathy.
Oh, you know what? That's actually okay. That's why I haven't. I think today I have about 6 my trainees are on. Don't worry. We love to help. And this is important. So Cynthia, that was a terrific question. And in fact, we did speak to the Long-Term Care Commission. So Jane, I am trying to get out there and influence policy. And when we spoke to the commissioner, he actually asked that question. He said, you know what, you're talking about getting all these nurse practitioners into these homes. Are they there? Are you going to find them? And I think it felt like, if you build it, they'll come. I'm thinking of that baseball movie that I watched once in a while. I really believe that's the case. I think I'm not, and I was working with Claudio Marino, who's the director of policy for NPAO, which is the Nurse Practitioner Association of Ontario. And there's quite a few nurse practitioners that come out every year. We do think, though, Cynthia, we would love maybe a little bit more schooling specific for MPs to learn more about long-term care homes and the regulations. So we might want to offer something along that lines. But many of them go into a sort of a more geriatric specific course. So I'm surprised, but I don't think there's going to be an issue finding them. Because I think, and this is what I also teach, because I teach graduate students at U of T. Hello, if you're a nurse, get ready. You're going to be a geriatric nurse, because that is the population we're serving in Canada. So if you're not interested in caring for older people, you probably shouldn't be a nurse. And I don't know, I'm pretty blunt. So I think they have to understand sooner or later that is the group they're going to be caring for, unless they happen to go into peds, or maternal infant.
Okay, we've got 3 more. So I'm going to, it's kind of like speed dating that I've never done, but let's go for it. Minaz, Mark Venning. So Minaz, what's your question?
Good morning to everybody. My question simply was that we seem to be dwelling on a certain type of a model, which we have developed in Canada and in many of the Western countries, of how to take care of the elderly. Yet, even in Canada, we have tremendous constraints. We do not have enough healthcare practitioners, nor is there a will from the politicians to allocate adequate funds towards it. Should we not, rather than having this discussion, have a more wider open discussion and look at best practices in terms of how both developing and developed countries face this problem, and come up with a model that is more practical and can be sustainable?
Okay, thank you, Minaz. You might want to actually come to the IFA conference in November, because we will have WHO talking about long-term care, and hopefully we can actually encourage Kathy. So Minaz, Valerie, and then Mark Venning.
Hi, I was a psychogeriatric resource consultant for many years, and then managed the behavioral support system for our region. And I worked with nurse practitioners who were wonderful, but like you, trying to change regulations, policies, and practice was challenging. Now that I'm retired, I work with one political party. There are 4, at least in Ontario. And I've discovered that even a regular member can introduce policy. And I have been trying for quite a few years to introduce policies about seniors and long-term care. But there are so many competing policies, the climate, business, you name it. But because the spotlight has been on long-term care and seniors in the past year, I've been very successful at introducing policies that have been approved and will go to the floor. One has been passed provincially, one hopefully federally. And I'm thinking that happens in every party. Any member can get other members to support a policy. And then even if it just gets to the point to being reviewed by members or looked at, there's more chance of it moving up, so that if it ever becomes policy, any candidate has to look at all the policies. If those people get elected, it will go further. And it's very high level, but it's a way to work towards the future.
Okay, thank you, Valerie. And Mark, final question, sir.
Yeah, so my concern is around this issue around the exodus of workers in the care field. We hear this in the news all the time. So it's about the recruitment for the future talent we're going to need. So how do we build a better narrative to help in the recruitment in the care field at large, whether it's nurses or whatever it is?
Thanks, Mark. Over to you, Kathy.
Wow. Okay, Minaz, I don't really think I have a good answer for you. I'm thinking about practical solutions, best country, I have to tell you, I'm still sold on nurse practitioners. And I think we have to understand, how do we globally influence this agenda? Because I think you need healthcare practitioners that have the knowledge and skills to care for this very complex group that we're seeing in long-term care facilities. When I did my PhD, which was 25 years ago, we had elderly coming in because they were interested they were lonely, so they were actually coming in and they could still have great conversations, have tea with their neighbors. This isn't happening anymore. People are coming in probably with about 3 to 6 months left to live, and they're very complex. So we need people that can actually care for them. And I think and maintain their health as well as we can, and their physical, social, spiritual. So you're going to need people to care for them. And I think it's going to cost the system. And that's maybe where I'm maybe being unrealistic, but that's my answer. Or we have to move funds around from one place to the next. I'm thinking of you, Valerie. Good for you. What a beautiful story. That actually has inspired me. So now I know what I'm supposed to do in terms of trying to influence. I've never thought of that before. So thank you. And Mark, I think this is going to be the challenge. And this is what my editorial was about. I wrote with, I have about 8. So first of all, remember I told you about my frustration about the RN. We had very few RNs in actual nursing homes. And we've seen the trend where there is even less of them now. And I developed an international group about 10 years ago. So about 18 of my colleagues and I wrote a column, editorial in May last year, because it was so hard watching what was going on. And we said there will be nobody working in nursing homes shortly, given what we've handed them and how we have really abandoned them, is how we all felt. And but I have to be an optimist because I think we have to be. I think this is a time to kind of create change. It's time to do something right and do it well. And I think we have to create this as a place where you're going to come and learn and thrive. This is actually quite exciting. A lot of people do love working with older seniors. We've got to capitalize and find them. We've got to pay them better. We've got to harmonize wages. I think, Mark, we've got to start looking at, this is not okay that we're getting paid differently when you're in a nursing home. This is where I'm thinking hopefully standards can start addressing some of this. Nurse practitioners don't make as much money, or RNs in nursing homes. This is ridiculous. This is a very complex group. We've got to change that. And I think what we found are nursing students. I was on a presentation a couple days ago where many nursing students made a huge difference during this pandemic because we had to have someone care for our seniors. And some of the nursing students, like never before, are choosing gerontology because they realize this is where they could make a difference. And that could be one of the beautiful side effects of COVID-19. We brought in a lot of nursing students and they changed their perceptions, and they realized this was a group they needed to care for going forward. So I think we've got to change, and I'm hoping with our nurse practitioners with more leadership, and the part that I sort of negated here, Mark, is we need leaders in nursing homes. We've got to focus on what are their skill sets. And I think these were my take-home messages, Jane, that I can maybe move right into. But Mark, I believe we can recreate a better nursing home environment and then get staff excited to work there again. And we just have to make sure they're supported and their mental health taken care of. And I think that's partly what our nurse practitioners / leaders can do.
Look, thank you very much, Kathy. It was inspiring for me to actually listen to the evolution of a new model. You know, that's what you were talking about. And I think at the heart of this is relationships, you know, and it's sustained relationships, and it's trust, and it's transparency, and it's accountability. But it's also about taking the opportunity and being bold, you know, having a stronger voice and having that voice sustained throughout, you know, the lumps and bumps of policy. I can't help wondering, though, that we're all leaders in an odd kind of sense, and that it really will need cross-sector, cross-discipline cooperation and dialogue, because it's too easy for decision makers to push aside, you know, the older population or, you know, those healthcare workers working in facilities. For me, I would like the word nursing home to go out the door. It's not nursing homes. You know, we need to have a different word, whether it's residential facilities, I don't care. But, you know, that's the kind of small but big leverage that we need to start thinking about and doing. So thank you very much for being in conversation with us at the IFA Global Cafe. It was truly a pleasure. And I do hope that you'll be coming along to the conference, but also, you know, we're going to loop back and have another talk with you later in the year to see what's really evolving from that. So thank you. I just want to introduce our next speaker at our next Global Cafe, and that will be IFA Director, Dr. Ad van Berlo. And Ad will be talking with us about smart homes and also e-health. So be with us next week. He's coming from the Netherlands to be with us for our coffee morning. And in the meantime, thanks, John, for being with us today and being the project lead on these global cafes, and also to Ashley and all of the IFA staff. It is about relationships that changes the world. So that's why we need to come together and be part of this growing community. So thank you, Dr. Katherine Mcgilton, and we'll see each other next week.
Okay.
Stay safe and stay well. Thank you.